Okay, without any further ado, welcome to the second in our first series of improvement showcases here from the Commission on Excellence and Innovation in Health. Our first series is Improving Flow, and we're really excited today to have Dr. Martin Ritossa here to present to us from the Northern Adelaide Local Health Network. So what we'd like to do is just really briefly give an introduction. For those that joined us last week, you'll be familiar with what we're going to talk through in the first instance, but really just to set the scene for what we're trying to achieve by hosting this opportunity for the health system. But first, we would like to acknowledge that the land that we meet on today is the traditional lands for the Kaurna people, and that we respect a spiritual relationship with their country. Also like to acknowledge that many of you may be on the traditional lands of other peoples. We acknowledge that the Kaurna people are the traditional custodians of the Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. So the CEIH, which is the Commission on Excellence and Innovation in Health, wants excellent health outcomes. We want excellent experiences for everyone, and we want to see consumers, carers and clinicians engaged in design and delivery and evaluation of health services. And ultimately, what we're hoping that's going to achieve is increased confidence and pride in the South Australian health system, a culture in the health system of innovation and striving for excellence, and that South Australia is recognised as having an excellent health system and as a leader in healthcare innovation. And to do this, the way that we're working is to build capability, provide advice and support, to partner and connect and bring people together and weave through the health system, and to look at opportunities for innovation, excellence and best practice. And really in doing that, we're looking to provide innovation support, if you like, to teams across the health system. And this is just one way that we're looking to bring you together. The idea of these sessions is really to avoid this happening. So the idea is that, you know, if we're doing something in one little pocket of South Australia, then actually we should be sharing that knowledge and sharing our learnings, and perhaps sharing where things didn't go so well across the system. Sometimes it feels a little bit like this, that the left hand doesn't know what the right hand's doing. And certainly that's been my experience working as a clinician across the health system. You know, sometimes I describe that I feel like I do up my shoelaces and keep walking, and I look down and my shoelaces are undone again. And particularly as you move around our health system. South Australia is really not that big, so let's get it together. And I guess also in terms of innovation, there's opportunities to do things differently, and opportunities for us to start to imagine and then start to put that imagination to work. And that's really what we're all about here at the CEIH. And really this notion of what if the big idea was connecting the small ideas. So the Improvement Showcase specifically, 1 o'clock on Thursdays, and then online whenever. So what we'll be doing today is recording a video up until the end of Martin's presentation, at which time we're really keen for you all to turn your cameras on and have a conversation. And to encourage you to do that, we were planning to stop the recording at that point in time. So we'll be recording the presentation and then turning off the recording. So we'll be able to provide that recording to other people, but we won't be recording the discussion and the conversation that we have afterwards, because it's really important to us that we have that opportunity for some really open and honest and robust conversation. The point of these sessions is really about bringing healthcare teams together and providing that space to explore what others have learned, but whilst keeping it simple. The idea is that people can come to this platform and share their stories without having to do a whole lot of prep. You know, perhaps some thinking, but there doesn't need to be, you know, a thesis behind every presentation. This can be an opportunity to come and tell a story. So our first series was selected as Improving Flow, and really what we want to do is move to a place where we're not selecting the topic, where we're not selecting the theme, if you like, and that's coming from you and what you would like to hear about or what you would like to share. But really what I'd like to do in the first instance is see that flow is really important to us, and the theme of flow, I guess, came from understanding that patient flow is the movement of patients through the healthcare system, and if patient flow through, you know, emergency departments, through inpatient areas, around length of stay and transfers and alternative pathways is really impacting on patient outcomes. And really this notion that we talk about pathways when we have a highway to our emergency departments. And so how do we actually develop really safe highways to other alternatives? And so in the first instance, we've invited some people to come and tell their stories. And we heard last week from the team at Flinders around the integrated management system. We're looking to hear from Martin today about what's happened in the ambulatory gynaecology unit. Next week, we've got the team from Flinders coming back again, a different part of Flinders, to talk about supporting quality assertive discharge. And then the amputee prehabilitation program from NALHN is our fourth in this series. So what we'll invite you to do is to keep your microphones muted during the presentation if you can. And we're going to ask Martin to talk for around 20 minutes. And as I say, at that point, we will turn the recording off and just give you an opportunity to open up the mics and have a conversation at the end of that. So without further ado, I'd like to hand over to Martin.
Okay, so you should be able to see my presentation now, can you? Yep, good, all right. So just quickly to introduce myself. I'm a medical officer, I'm a gynaecologist. I'm also an endoscopic surgeon, and hence my interest in the ambulatory gynae unit, which I work in. I'm a teacher. I'm also divisional director of the Women's and Children's Division of NALHN. So I'm sort of here in, I guess, most of my roles, actually. I too would like to acknowledge the country and the lands we're on. And at NALHN, we're sort of trying to do this in Ghana, so bear with me. So NALHN tapanithi Ghana minya yicha, yatamathana Ghana yatanara, nagalu wapalinthi. Naganu tapanithi Bokana Bokanaka Yalaka Takaricha. Naganu Tampaninthi Yaicha Matinia Kuma Pakana Tula Yatanka. And the translations for there to you read along. So what is the AGU? So I'm assuming that you guys know nothing about gynaecology, which is good. I know nothing about innovation. So the AGU it's patient focused. It's day case procedures. And it's done with a local and often no anaesthesia. So unlike traditional surgery, there's no fasting required, no transportation or accommodation support is required. The patients can drive themselves to the procedures and drive themselves home. And really, apart from the time for the procedure and maybe the rest of the day, there's really no time for work off. They don't need any time off work, so they can go back to all normal duties pretty much that evening after the procedure. It involves two procedures. It involves LETS, which is a treatment for abnormal pap smears, and we've been doing that for some time. But we're going to focus today on hysteroscopies, and that's our focus today. So what's a hysteroscopy? A hysteroscopy is an investigation where we use a telescope to look inside the uterus. So it goes through the vagina, through the cervix, and into the cavity of the uterus to investigate the uterus for abnormalities of the endometrium or the lining of the womb. So why is our service different? Well, the AGU is the first unit in South Australia to see and treat. So outpatient hysteroscopy is done for many years. I started in a unit at the Lyell McEwen when I started in public as a consultant almost 20 years ago. There's been outpatient hysteroscopy at Modbury previously. There is outpatient, I believe, outpatient hysteroscopy units at both Flinders and the Royal Adelaide, but they don't actually treat patients. So, and the treatment's been enabled by some new technology, and I'm just going to run through a little video here just quickly to show you what we're doing. So that little lump there in the middle is what's called a polyp. It's a growth in the uterine cavity, which you'll see in a minute. It's quite small, it's only 1 centimetre. So we can pass this little device, which is like an mini apple corer, you'll see in a minute, that can just chew up the polyp. So you can sort of see it's got a blade just above that black line that moves backwards and forwards, and it munches up the polyp as you go along. As the polyp disappears, you can start to see the cavity of the uterus in the background. The dark area at 2 o'clock, and again at about 7 o'clock at the opening of the fallopian tubes where the egg comes from. So we're cleaning out the cavity. This woman's postmenopausal, so the cavity is very thin and atrophic apart from the polyp. So treated the problem, got rid of the bleeding, ruled out cancer, all in sort of one session in outpatients, as I said, under local or no anaesthetic. So these are the questions I was asked to deal with today. So how the need for improvement was identified, how the improvement was designed, how was the improvement implemented, what evaluation was done, and what lessons were learned. So I'll go through those questions now. So how was the need for improvement identified? Well, we've known about this for years. Best practice guidelines in Australia, England and other places have talked about outpatient services being outpatient for hysteroscopy. Treatment's been undertaken previously with, I guess, more basic technology than this, but this is not new as far as the world's concerned. And as I said, we've had outpatient hysteroscopy before, but just never with the treatment. It's obviously cost effective, or we at least assumed it was cost effective. But I guess the new thing that's come upon us recently, particularly with COVID, is the waitlist pressures and how can we efficiently do perhaps extra operating, or at least do the operating that we were supposed to be doing previously. However, we've been burnt before when we tried to instigate things. So whenever we want to do a new service, it's increased activity. We're not funded for that activity. We've got to buy all this new fancy equipment, which no one's prepared to pay for. What about the staffing? This required specialised staffing, and I've just heard today we're in trouble with the unions because we hadn't consulted with them, even though it's now been up and running for over 9 months. It's been running for. Education and training, and introducing a new procedure, which is problematic in itself. So when excuses, so nothing ever gets done. So when we want to introduce a new procedure at NALHN, these are the steps we need to go through. So we have to get approval of our manager of the unit, work health and safety, biomedical engineering, risk manager, business consultant, medical records and documentation, strategic operation manager, ICT, infection control, products evaluation standards committee, drugs and therapeutics. We do use, in the local anaesthetic and stuff. Research committee. Luckily, we didn't have to go to the research committee because we're not doing any research in theory. Aboriginal health manager, credentialing committee, clinical governance committee, and then the CEO. And then finally, you can do a new procedure. And interestingly enough, for any craft group that was putting through a new procedure, there may not be anyone or very few people in this whole process who are in their craft group and actually understand the new procedure, what it's for, and be able to actually argue for it, or in fact against it if they don't think it's a good idea, because these are all outside of clinical realm, most of these committees. So we stopped, and you hopefully all know about the Mobbery redevelopment, and our plan was, once the Mobbery redevelopment happened, to sort of get something up and running then, because we're getting 2 procedure rooms which would be dedicated to procedures, and we thought a lot of the arguments for infection control and various space and various other things would go away with the new procedure room, rather than an area that wasn't purpose built for it and was built 30, 40, 50 years ago, despite having done the procedures in those rooms before. Anyway, then COVID-19 came around, and COVID caused theatre stopped, so wait lists went up. Combined with that, we had the Mobbery Hospital redevelopment, and somebody had the great idea that because what we were going to do with Mobbery Hospital was we're going to close 2 theatres, build, and then when those 2 theatres were ready, open them up, close the other 2 theatres, and then finish the build. And someone thought, well, if we're shutting theatres for COVID, why don't we just close Mobbery theatres altogether and just whip through the building process as quickly as we can, saving about 6 months. So that was the plan, but unfortunately COVID didn't happen. Well, fortunately COVID didn't happen. So we ended up with a closed operating theatre and an increased waiting list. So we had the perfect storm. And so in stepped Martin and his team, and we said, we've got the solution for you. We can do outpatient hysteroscopies, so we can take those cases that are supposed to be doing in theatre, do them down in outpatients, and we can run with it. And bang, rubber stamp, no problems. So how was the improvement designed? Well, it had past experience in SA Health of doing this, as I said, both as inpatients, which is the traditional way of doing it, but also we had outpatient experience. It's not that radically new. We could do literature searches on the new techniques, and we are doing it in different ways than we were doing it in the past. And we've learned from centres of excellence in Australia. So we'd phone, email, have conversations with there's a couple of units in Sydney and Melbourne particularly who are doing this sort of ambulatory sort of hysteroscopy and operating on patients in the outpatient setting. So we had conversations with them. We used shared protocols, all those sorts of things to get it up and running. How do we implement it? Well, it was fast-tracked, as I said. Funding was achieved for equipment through the grants from the Research Foundation, so something we had access to that money, which we wouldn't have before. Nurses were redeployed from theatres because they were previously working at Modbury Hospital. They had nowhere to work, so they needed to be redeployed. So all of a sudden we had staff that we wouldn't have had access before. And through the hard work and dedication of my head of unit, Kate Walsh, the NUM in charge of Modbury Outpatients, Noel Dewhurst, and Amy Phillips, who's the theatre nurse that came down and helped us, we were able to get the work done. So a different type of storm was happening. We had a sort of tornado or a tsunami rushing through of activity to get this up and running as quickly as we possibly could. So how was it implemented? Well, we streamlined the booking process, so we avoided the pre-admission clinic, but we still had the theatre bookings doing the bookings. We had established a nurse-led clinic to contact patients a week prior to the procedure. In that clinic, the nurse went through a standard questionnaire, which was tailored to the procedure. So we looked at the indications, we had that. We looked at risk factors that might make them not suitable for outpatients. We also looked at their suitability for an awake procedure, because not everybody is suitable for it. They might be, might not be happy to have it done. They might be difficult to examine, all these sorts of things. And we also provided the patient with a lot of education. So it was very nice that the nurse that spoke to them on the day was also the nurse who was in the procedure. And so that patient had that confidence, even though they had met them before, they'd spoken to them on the phone. And doing stuff in outpatients is all about confidence. And the patient has to have confidence in the staff to undergo a procedure while they're awake. Training was set up regarding all the equipment, and the reps came in from the companies and upskilled all the staff on how to use the new equipment. And a post-operative phone call clinic was also organised, so we could ring them a couple of weeks later to make sure that how they were going and the results. And 2 PPGs were written outlining the booking process and also the procedure, and they were put up on the PPGs before we got started. So all this work was done probably in just over a month, month and a half or something like that. So a lot of work was undertaken. What is the evaluation of the improvement? Well, to date, we've done about 148 procedures or hysteroscopies. We've done some of the LETSs as well. We've looked at costing at this stage. It's probably the main thing. And previously, the cost of performing these procedures in Modbury theatres was $3,254 per case, or 27% above the national efficient price. The AGU cost has come in at $1,541 per case, so 40% below the national efficient price. So that's to date, we've saved $250,000. And look, to be fair, we've probably burnt most of that money in the equipment, which was donated to us anyway, but equipment and various other setup costs, but we're well and truly now cost neutral in making a profit for the organisation. And there's going to be ongoing formal evaluation, including procedure success rates, reoperation rates, conversion to inpatient rates, and patient satisfaction rates. So we're going to do that piece of work. We've been doing it as we've been going along. We'll get instant patient satisfaction. We always ask them, would they have the procedure again? They're all very happy. We bring them 2 weeks later. We've been tracking, I guess, in our heads the number of successful procedures to make sure that we're doing the right thing. But we're going to sit down and formally do that now that our case numbers are significant enough to be able to do that. So, however, so that's all the good news. I guess the bad news is 9 months on, until very recently, the purchase of the dedicated equipment enabling clinic to continue at the Modbury Theatre after the Modbury Theatre's opening was not approved, but we just had that done. So we borrowed equipment from theatres, so that had to go back. So we needed some equipment. We had purchased I guess, the specialised scopes. We hadn't purchased the tower and the fluid irrigators and whatever else we needed. So we've got that approval for that now, so that's great. That's just come in the last week. We need to transfer some nursing and admin FTE from theatres to our division to pay for it. So at the moment, this is a cost pressure on our division, because although we're paying the salary of the nurses come across from theatre and the admin staff that do the work for us, so we're talking about 0.8 FTE, we're not funded for it. So we still have to get that organised. I believe that's underway and that's happening, but that's, 9 months down the track, it still hasn't happened. So it's just the little things like that have you bashing your head against the wall, because everybody knows it needs to happen, but it just doesn't happen. And I will say that we've had very good support from the people above me, the COO and the CEO and stuff. They're all very, very supportive, but these things just take time. What have we learned? Well, we've learned that nothing is impossible, and that persistence and patience pays off. And if there's anything I've learned in this game, is it's always a two-year sort of plan. Nothing happens too quickly. To achieve success, you need to have a great idea, a great team. You need to be able to communicate the advantages, and I think that's very important. I don't think people don't realise that. You really have to be selling what you want to do well in advance. You need to be talking to the people who are going to approve it, get them on board before you do the work, rather than doing the work and just hitting them with it, smack in the face and among a million things they have to deal with. So you need to take the team, all the team, both people who will be doing the work and the people who have to approve it along the journey with you. You need to educate everybody. Certainly need to evaluate. And we obviously did costings beforehand, but they were always going to be theoretical. Costing stuff is actually quite difficult. I don't know whether anyone really no one can tell me instantly what an operation costs or how much staff we use in theatre. That's all stuff that we need to work through on a case-by-case basis through case mix after the fact. It was very hard to tell it before the fact. And we need to reinforce. So the big risk for us is that we'll all fall back into our old habits. COVID will go away. Patients will want procedures under general anaesthetic, or at least we think they'll want their procedures under general anaesthetic. The surgeons won't want to book them because they want to hold on to their own patients. And we'll all fall back to this old habits, and the clinic will sort of die away, which has happened in the past. So where next from here? Well, to stop it dying away, we want to establish a one-stop shop. So direct referrals for suitable patients will be screened, for example, postmenopausal bleeding, or a Mirena is a contraceptive device which is in the uterus, and not infrequently the strings go missing. So you need to do a procedure to take those strings, grab those strings and pull the Mirena out. And this is ideal for that. So you have patients like that who can really just, you triage them straight to the pre-operative phone call, straight to theatre and out, very efficient. And that way you're actually getting the patients from the GP referrals. And look, interestingly, we've already had some direct referrals from the GPs. The news got out very quickly to the GPs that this was happening. But to do that, we need to open a triage booking phone clinic, and that's a new service. So we hit our roadblock again. But we can see the light at the end of the tunnel. We'll solve the problem. That's not an issue, because humans crave challenges. Fostering a culture of change promotes advancement, but stifling change leads to stagnation, staff dissatisfaction, and ultimately service issues.
Fabulous. So I just quickly want to flick back and offer an opportunity, I guess, to those that are on the call to speak to peers and colleagues, and I guess to look at opportunities perhaps to reach out and share your story. But that absolutely, if someone's out there who's not got the capacity to produce a PowerPoint, for example, we're really happy to invite you to come and tell your story anyway. And so I guess really it is, have you succeeded in solving a problem, or have you not succeeded, right? Have you learned something whilst trying to solve a problem? And how can you have that opportunity to share that with your peers working in health? And really what we're looking for is to have some consistency to the way the stories are told, so that we can start to develop maybe some answers around how did I know I had a problem, and those sorts of questions. So that's absolutely what we're looking for. We're also really keen to hear from people about the themes that they might like us to explore. So flow was our first pick of the rank. May is still an opportunity. If anybody's got a suggestion for where we should go in May and the months ahead, and really just, anything's possible. So perhaps if anyone's got any ideas, please contact us through our website, ceih.sa.gov.au, and you can go to the contact us page and get in touch and let us know, or give us a ring if you know us. That's fine too. Thank you to you all for joining us, and we look forward to seeing you next week at the same time.